afternoon everyone. First of all, I want to congratulate AMOGS for such a wonderful organization, and really thank you very much for considering a neonatal corner as a topic of discussion, because whenever we want to avoid the mishaps in the labor room, then avoiding the mishaps in neonate is equally important, because we are doing all these things just to have a healthy baby. Okay. So my topic is basic neonatal resuscitation. We had this discussion many times. All of us are practicing from so many years, and daily we are seeing these babies who are coming out, and some of them may require neonatal resuscitation. But why we are discussing this, the important thing is that this is the topic which has lots of updates. Every year there are some or other new recommendations, new guidelines that helps to prevent the morbidity and mortality in the newborn. So neonatal resuscitation means to revive or restore the life to a baby from the state of asphyxia, and aim is to do the necessary steps to ventilate a newborn baby who is not breathing and protect the life of the baby. So the important aspect is ventilating the baby, right? Many times we see that baby cried, but the respiration may not be proper, and this child may still require further resuscitation. So these are the various risk factors. Jayan sir has already told that you have to anticipate which child may require resuscitation, and so we all are aware of this, some antepartum and some intrapartum risk factors. As sir has correctly told that we need a teamwork. So many times the common mistake that happens, we just ask the pediatrician to rush. Just a pediatrician rushing at the place is not sufficient. We need a place, we need a setup, we need an assistant, a helper, and the whole teamwork is very important for the successful resuscitation. We have to have a leader, one who will guide other teammates to resuscitate properly. And what personnel should be present at the time of delivery, sir has already told. Various things that are required, that also sir has told. And sir has told what questions we ask the obstetrician. So again I want to remind here that please update these things. Sometimes it becomes very difficult for the pediatrician to hammer again and again and ask this question. So let the staff be prepared with these questions, and please answer on yourself without asking these questions. And specifically I expect these questions to be answered whenever somebody is calling the pediatricians for the delivery. And it will be better if a resident doctor or doctor herself calls the pediatrician. Many times sister only calls ki sir ek gravida 2 आहे किंवा प्राइमी आहे, आणि बरेचदा रिस्क फॅक्टर सांगितलेला नसतो. If the mother has received some general anesthesia, or she has received some anticonvulsant, if she has received some magnesium sulfate, we might have to be prepared with many other things or advanced resuscitation. Now this is the exactly the protocol. I will be saying what exactly is the protocol for resuscitation. What I want you to know is, have this particular protocol printed and stuck up at your neonatal corner. These are the steps, because if you do it methodically, it is going to prevent the neonatal mortality as well as the morbidity. So doing the things stepwise and in proper manner is very important. As soon as the baby is delivered, the rapid evaluation we see whether the baby is term, how is the tone, whether breathing or crying, and also whether there is a meconium. Again the same thing, if baby is term, full term, everything is, baby is crying well, we give a routine care. Okay? And this is the new thing. See, I am not going to talk that what we all are doing. What new things we will be taking from this workshop, that I will like to highlight over here. This is something which has been recommended, that delivering the baby on the mother's abdomen. Is there anyone who is regularly delivering the baby on the mother's abdomen? That's good, that's good. Because see, but there are very few number, and we have to increase this number, because now it is almost 3 years that these recommendations have come up. Again about the delayed cord clamping. Probably we are not implementing, very few of us could implement it, because waiting for 1 to 3 minutes. The common habit is, tray is ready. As soon as the baby is delivered, we cut the cord, we clamp and cut the cord and hand over the baby. So these are the things which probably we may change. This is the routine care. We provide the warm, like by cleaning the baby and giving the clothes and all, suction the mouth only if necessary. Even if there is a meconium and child is crying well, we do not need to do a suction. Cut the cord after 1 to 3 minutes, keep the baby with the mother and initiate the breastfeeding. These all things are important. Just crying the baby is not important, because thermoregulation as well as preventing hypoglycemia are equally important to prevent the neonatal morbidity. Now this is a low risk newborn, is a full term, good tone, crying baby. And this is a high risk newborn, which is preterm, there is a poor tone and not crying. We should be able to identify these babies who does require a neonatal resuscitation, and these babies we have to cut the cord immediately. We need not to wait and then take the baby to the radiant warmer and start resuscitation. When we do a resuscitation, first thing, initial steps are place the baby under the warmer. We cut the cord, tell the mother that your baby may require some intervention, and we are taking the baby under the radiant warmer. And then initial steps are providing warm, position the head and neck, clear the secretions, dry and stimulate. Now these are very simple things. But those babies who do not cry immediately require these steps, and they has to be as per the sequence. That is very important, that doing these steps as per the sequence. Now the position is very important. We all should have that particular shoulder support, 1 to 2 inch roll, shoulder roll, that should be below the shoulder. There should be a shoulder support, and there should be a semi extension. It should not be a flex, it should not be very much extended neck. So sleeping position we call it, and then we clear, a suction is to be done. As sir has correctly said, that particular bulb is usually unhygienic, and so the least mucus extractor that we can even suck, even in the absence of your electricity, even if your suction machine is not working, we can do a suction. So we can use that suction. Okay. Then drying, and very important is remove the wet linen, because again that wet linen itself is responsible for causing the hypothermia. And then stimulation, we all know the various methods of stimulation like sole flicking and back rubbing. And assessing the oxygen need, this is something new addition. We have to check, if possible, we have to check the pulse oximetry. Many times baby may cry, but the breathing is somewhat, there is some nasal flaring, and the baby is not able to maintain the oxygen saturation, and maybe that baby may require further resuscitation. And those babies who require these position, suction, stimulation and resuscitation, these are the initial steps. This baby requires observational care. These babies may show convulsion, may show hypoglycemia, may land up into some or other problems. So these are the targeted preductal saturation. What is preductal saturation? See, the baby's brain and heart is getting the preductal supply, cardiac blood supply, and so if we want to check the preductal saturation, it has to be checked in the right arm, okay, because our left arm and the lower extremities of the babies are getting postductal supply. So if we want to see the preductal saturation, the pulse oximeter sensor has to be applied on the right arm. Remember this thing. Now this is our, usually we do have this pulse oximeter and the saturations. We may supply the oxygen. These are various methods of supplying oxygen. Bag and mask ventilation, it is the most important thing, single most important thing is, and a very effective step in the neonatal resuscitation is bag mask. And we have arranged the bag mask station here. Being a workstation, we expect that all of you do practice how to bag mask effectively, okay, and different these things you have. I will just finish up in few seconds. The mask, how to apply the mask, that is very important, properly applying the mask and doing the bag mask. T-piece resuscitator, this is new thing which you can take up with you, and if possible bring in your neonatal corner. These are again the further same steps of neonatal resuscitation. If you cannot successfully or properly doing the bag mask, check these steps, whether the mask is applied properly, whether the position is proper, all these things. And positive pressure ventilation is successful when there is a rapid rise in the heart rate and improvement in the oxygenation. And even after the resuscitation, this child may require a post-resuscitation care. You have to monitor the blood sugar, you have to monitor the breathing and temperature, you have to see for the complications. These are the things which are required. You may require intubation sometimes. So this is usually the advanced resuscitation. We don't require every time, but maybe 1 in 100 we may require these things. This is one thing more new, that is laryngeal mask. For intubation, you require laryngoscope and do the intubation. You need to be expert, and every time it is very difficult to do that in things. But so laryngeal mask, you have to just push the tube into the larynx and you can ventilate the baby. So this is another thing which we can have in our neonatal corner. So chest compressions and the medications we rarely require. Only take-home message, updating the delivery room staff in neonatal resuscitation is must. Prepare the neonatal corner and keep it updated to prevent the morbidity and mortality in newborn. And teamwork is needed for the successful and efficient neonatal resuscitation. Thank you very much. Thank you.
Thank you, sir.